Good morning, everyone. Can you? Yeah. I'm going to present you a specific complication that we saw in Garch after a COVID crisis, which is related of our specific activity that we have in interdisciplinary consultation. We see a lot of people with patients with neurogenic heterotopic ossifications, and so after COVID crisis, we saw a lot of people coming heterotopic ossifications that occur after COVID. So we decided to look better these cases that we got in interdisciplinary consultation. So pretty much all the patients with consulting for heterotopic ossification after COVID until the 1st of June 2021, because we had a student who did the amazing work of a retrospective study. So she had to look in all the cases, in all the patient folders for informations. We did that in Raymond Poincaré Hospital, but also Percy Hospital. We met Nicolas de l'Escalopier yesterday, who also do surgery on HO in Percy Hospital. So this student collected data about patient, about complication that patient had in intensive care unit, data from interdisciplinary consultation, clinical and functional patient complaints, and also features of imaging and surgical features about HO. So what we got, it's 14 patients with a median age of 56 years old. Most of the patients were males. We got only 2 females, and most of the patients were presenting HO after the first wave. Most of them, half of them were presenting on overweight. Some of them had pressure, dyslipidemia, for what we saw on COVID patients from the first wave. And we also had 25 HO for 14 patients only. That means that one patient could present more than 1 HO, and it was actually more than half of our population was presenting 2 or 3 HO on different sites. Most of the sites were hip, as the usual HO population. It was the hip coming first. Some other were presenting HO around the shoulders, also the knee and the elbow. For the results, we saw that all the patients stayed in intensive care units, so presented a very severe form of COVID complications, and the length of stay in intensive care unit was 47 days. All of the patients got a mechanical ventilation, they got Curair, medication for sedation. And what was interesting, it was when we looked a bit better to the corticosteroid administration. It was only 3 patients who got dexamethasone with a high dose, and all these patients were patients who got COVID of the second wave. For the first wave, or in intensive care unit, medical doctors were not using corticosteroids at high dose. Patients were usually put in prone position therapy. Most of half of the patient got 5 to 10 times of prone therapy. And we also, when we were asking questions at the patient during an interdisciplinary consultation, one thing was coming back all the time, is that the patient were presenting neuromuscular abnormalities acquired in intensive care units. So they got motor and loss sensitivity during few weeks or few months, and they were recovering usually well when we were seeing them in interdisciplinary consultations. Then other patients also presented infection, pneumonia when they were ventilated, so bacterial pneumonia. And 3 patients complained about pain, joint pain, probably in intensive care unit. So they got X-ray in intensive care unit just for 3 of them out of 14 patients. So what we saw, it's so usually the patients were coming to see us 6 months after the first day in intensive care unit. They were complaining usually about stiffness for more than half of them, but also for pain, and sometimes it was combined pain and stiffness. What we observed is that the patient complaining about stiffness, 5 of them presented hip ankylosis, and it's the complication that we don't like for an HO patient, because we know that if we wait for too long, we can see a loss of the density of the femoral head and neck, and they might present a bone fracture during surgery. So we don't really like this complication, so usually we propose surgery as quick as we can. So surgical excision was indicated for 17 HO. 2 patients refused the surgery. I will explain a bit later why. And 11 HO has been removed so far, pretty much 1 year after admission in intensive care unit. So it's pretty fast in HO field. One patient present asymptomatic reoccurrence, and we didn't see any infection after surgery. So we know that people who spend a lot of time in intensive care unit, even if it was not for COVID reason before COVID, we know that a patient with after surgical complication, for instance, who spend a long time in intensive care unit, they can have HO, but they were super rare, and the common risk factor for all the pathology that that can lead to HO formation is the admission in intensive care unit, the long period of mechanical ventilation, surgery, but also infection. And one risk factor very interesting is a long period of immobilization that we that is coming in regularly in retrospective studies. And then we don't have a lot of data about HO occurring after intensive care unit, but what we can see in other kind of disease leading to an NHO, especially an HO formation, it's the long stay in hospital, but also associated trauma, long delay before physio, and the long delay before joint mobilization. So HO after COVID, we are not the only one who described the complication. We saw a few papers coming in, appearing in the literature. And what we could see, it's HO after COVID. It's like an epidemic of HO in our service. We really feel this in interdisciplinary consultation. We didn't have much traumatic brain injury or spinal cord injury during COVID because everyone was in lockdown, so no drama, but HO post-COVID. And it was the main purpose of the consultation. So we are still working on that, but maybe there is specificities about imaging. So we are working on that with our radiologists who are also specialized in HO. Maybe there is a specificity in architecture, especially when we talk with Fabien, who has done a lot of surgery on HO after COVID. Maybe the HO is not exactly the same as neurogenic heterotopic ossification. They look like more close from the joint capsule. And maybe the histology is not exactly the same as the regular neurogenic heterotopic ossification. And as we are working with a team in Percy Hospital who is analyzing all our HO that coming from the OR, we are actually looking at the histology right now to see if they have the same specificity or not. So what we recommend, even if it's still rare for teams who are doing neuro-orthopedic, it's to manage the HO post-COVID, like neurogenic heterotopic ossification. because in this patient, we want to detect HO early to be able to follow the patient early, because we are always afraid about complications, and especially COVID patients, they usually recover really well compared to a spinal cord injury patient or traumatic brain injury. These people keep a bit of disability, but HO patients, they recover really well. So when they come to see you, they ask you to, I want to run again, I want to go back to my work again, I want to drive again. So you have to, they have all expectations. So we have to assess properly this patient, because they have a high expectation. And as for neurogenic heterotypic ossification, we do surgery only if patient is complaining for something. And we saw some patients who are traumatized after COVID crisis. They spend 3, 4, 5 months in intensive care unit. They don't want to have surgery, even if they are bothered by the HO, because they don't want to spend 1 day in the hospital. It's also traumatizing for them just to come to the consultation, and as soon as they see you, they say, no, I don't want surgery, so I'm blocked with my elbow, but I don't care. I don't want surgery. Another point was before surgery, so interdisciplinary consultation is needed. We agreed about the aim of the surgery. And you met Shoki yesterday, our favorite anesthesiologist, and he's telling you, I don't like COVID patients because they still have fibrosis in the lung, and I'm not sure if I put a tube in their throat, if I'm going to take it back. So HO surgery, you have to keep in mind that it's bleeding a lot. It takes a few hours for the surgeon to remove the bone, so they are after the surgery they lose all their energy, and if the anesthesiologist can't take the tube back, it's our friend in intensive care unit. It's a functional surgery, so we have to be sure that after the surgery, patient we have to manage it well. So thank you for your attention. It's just to finish, because I know that Flavia is here, and the Montpellier team didn't have any HO after COVID, apparently. So we are going to work on a retrospective study, but to compare a bit our practice in intensive care unit, because apparently Montpellier used corticosteroid with high doses during the first wave. In Paris, we haven't done that, so maybe there is something. Yeah. Thank you very much.
Thank you, Marjorie. Thank you. Alberto, one question. Yes.
One question, a quick question, Marjorie. It was a nice presentation. It's, I think, very important information. We, in our rehab hospital, we opened a acute COVID unit, and we hosted about 250 patients, and none of them had HO. So it's intriguing of why that happened here. The other point is you appear to have intervened very early, unlike what we do with neurogenic HO. And so I expect that you're going to get some recurrences. Hope not, but could be.
Yeah, it's a good question, Alberto. We are going to see, because we are following this patient. So Fabien is still seeing the patient in consultations after surgery. They are still in intensive rehabilitation. So the knees, usually they are quite good. They are recovering well. We are more worried for the hips.
Yes.
And the elbow. Yeah.
I saw yesterday a patient who have osteoma in the hip with post-COVID, and he has also Parkinson's disease, severe, with akinesis and tremblement, and is the first one to have severe recurrence of the osteoma, and very stiff, only 2 months after the surgery. So I think people who have neuropathology that goes on is more risky to have a recurrence. Yeah. Because the other patients, after the COVID, when they recover completely, they walk very fast for the knee osteoma, for example.
And they don't have
very
the inflammation general inflammation in their body anymore. So, but because François didn't understand the same question, but for neurogenic heterotopic ossification, we usually perform surgery also quite early, because we in a big database that we have in Garches about NHO that Philippe have been doing surgery since 1993. We didn't show any difference between the where early surgery versus late surgery, and with early surgery we had the feeling that we avoid the problem of ankylosis with the bone loss and the risk of fracture. We avoid bed sores, we avoid cognitive disorder because people were so in pain that they couldn't even think or walk. So now we open them pretty early.
In contrast to you, Alberto, I have a 20-unit bed, and I had 4 cases in the first wave. So probably you did something in the intensive care unit we didn't do. Same for Montpellier. So it was quite strange.
No.
I confirm that I have done just a fast poll with my neighbor, Franco-Italian, about HO in COVID, and we haven't seen any HO during all the...
Who in the audience had HO after COVID in their patients? So it's okay. I will immigrate in America.
No, but it's important because we still don't understand the physiopathology, and also in the traumatic population, like in neurogenic heterotopic ossification.
Have you seen the same number of HO during the first phase and the other phase?
No.
Because you know that there is a real improvement of reanimation during all the phase.
Exactly, but it's exactly our thoughts, and that's why we have to work with Montpellier team, maybe Toulouse now, because there is something that happened in the first wave in Toulouse-Montpellier that we haven't done in Paris, because we got a lot of HO from the first wave, and we didn't have many HO for the second wave. And even now, like we don't see during some consultation, we don't see HO for post-COVID patient. They are the regular HO coming, so traumatic HO after.
We have a few patients in the first phase, more patients. No, it's finished.
Okay. Dominique, you have a question?
We had also a huge amount of HO after other viral epidemics. It was chikungunya and all that, you know, H1N1 viruses, and there is also a specific, you know, situation in Garches because we have a lot of surgeons. Yes, it's like a bias recruitment, you know, but with all the epidemics, viral epidemics, we have a lot of HOs. Not only this one.
I think this discussion is really interesting and shows very well what we should do in such a situation. And rather than performing a study with 1 or 2 centers, my suggestion is in such cases we should try to set a multicentric retrospective survey with a clear hypothesis regarding HO with COVID in the COVID situation. And we should try to revise all our thousands of observations in France. Maybe we could include some Belgian colleagues if they are willing to do that. And this is the only way to get an answer, because we thought that some of us said, oh, there is not at all no HO during the COVID. Some others say, yes, 1 or 2, etc., etc. The only way to get a clear answer and to make the science advance is to do such a study. So please, could you try to take the lead and invite us to...
No. No, but the point is we are actually we are going to start a prospective study thanks to the US DoD. So Department of Defense, they are going to find with like a big amount of money, so they are going to find a prospective French study and fundamental studies in Australia, because we are still working with the Australian team on the mouse model, and we feel that we are stuck. So it's exactly what you're saying. We are stuck at some point. We don't understand what is making this HO appearing, and COVID is the good opportunity to try to maybe work on another, not neurogenic, but maybe another field of HO, and maybe connect the HO, because they are quite similar, even if they are a bit different, they are quite similar. So yeah, we should do that.
We all are willing to help, and so please.
And Jan wanted to ask a question. Yeah. They didn't have any COVID in Australia, so they don't have HO.
Yeah, I'm sorry to pollute the symposium with an Australian accent. I've been very quiet the entire time. My understanding with heterotropic ossification is that it's linked with cytokine storm. And so if you don't have cytokine storm, you don't have heterotropic ossification. So I assumed that was a link with dexamethasone and when that became standard treatment. With paroxysmal sympathetic hyperactivity, it's only the patients who get sort of HO is 57 times more likely after TBI if you've got PSH, and I've always assumed it's the same process. So I'd just be interested in what your thoughts were.
You mean the inflammation? Yeah. It's our feeling. Yeah. It's the inflammation is the common point about all these diseases that are leading to an HO. Like when you are burnt on a big part of your body, you reach a certain level of inflammation. So the cells are sweeping from muscles to bone. It's our feeling, and it's the same in neurogenic HO. It's the same in intensive care unit with COVID. Like it's the big storm of inflammation. And yeah, at some point, it becomes bone. Because
Yes, but also I don't think so that inflammation is a sole element. I think it's largely more complex. Yes, I think immobilization is really, really, really important. So the association and trauma, yes, and this is really, really important. And all this, because you have some heterotopic ossification for severe ICU care, pancreatitis, all that stuff, And so I think there is a link between immobility, inflammation, trauma, and what is really curious when we work on the database for osteototic ossification after burns, we compare the care between Belgium from France, because there is 2 units for burns in the military hospital, which are exactly the same number of beds, same number. And the only difference between the two is that there is a lot of physiotherapists in the Belgium team and only 2 in the French team. And when we compare the mobilization of the limbs and that stuff, I think you need to mobilize your patient, not very, very hard, because maybe it can create some muscular lesion or something like this. But the immobility, in my point of view, is very, very important, and so that's why we need to... Yes.
I was just going to add one more thing, and that is that we know that COVID affects the brain. And so there could be neurotrophic factors in that.
Exactly. Yeah, you're totally right. Yeah.
Yes. And for the burns, we could isolate the curarization as a major factor risk, and the utilization on fluid beds. I don't know how to say that. Fluid beds, and these 2 more factors that we found, for burns. And maybe for the COVID, there is some people who use, curarization or not for the problem of the lungs, and maybe it's also one point we have to search a little bit.
Yes, I just want to share something with you from Martinique, because we had a lot of COVID, but our waves were later than many more in France, so we had to learn a lot from practice from others, and early use of steroids and we have no HO seen from now. And about what you're saying about mobilization, we had a lot of patients with great problem of obesity and less resources to mobilize those patients, and we didn't see so much HO. So we have to do this examination to learn about the physiopathologics, and but we had a lot of neurologic manifestation about nerve compression with drop foot and upper limb complication with neuropathic pains, a lot of them. And we have a lot to learn with COVID and physiopathologics on nerves and things like that.
I suspect we have the title of the next SNOF Congress, and so Marjorie, you will present the results. It's time to go to work, okay?